Welcome to my lecture on Introduction to Tracheostomy Care and Management. The topics I'm going to include in this lecture are airway management, hypoxia, indication for the tracheostomy, management of the tracheostomy, types of tubes, communication with the tracheostomy, speaking valves, and complications. Learning objectives in this video are describing a focused respiratory assessment, describing signs and symptoms of hypoxia, nursing management of the hypoxic patient, nursing management of a patient who requires a tracheostomy, the steps involving tracheostomy care and suctioning an airway, and explaining communication methods for a patient with a tracheostomy. I'm going to start with our definitions. A tracheotomy is basically an incision made below the cricoid cartilage through the second and fourth tracheal rings. Tracheostomy is the opening or stoma made by the incision. And a tracheostomy tube is the artificial airway inserted into the trachea. So why does your patient have a tracheostomy? Well, it is surgically created to bypass an obstructed airway, such as a tumor, laryngeal edema, a foreign body obstruction, facilitate secretions, preventing aspiration, permitting long-term medical ventilation, or decreasing the work of breathing like COPD. Another airway that patients can use is an ET tube, but what are the advantages of tracheostomy versus the ET tube? Well, let's draw our patient who is basically laying down here. So here's our patient laying down. There's little eyebrows, eyes. And here is the actual ET tube. So what are the advantages of having a tracheostomy versus the ET tube? Well, we all know that the trach is going to be a more secure airway. It's definitely going to increase the mobility of secretions. It's a less risk of long-term damage to the airway. You notice you got your huge, long tube traveling down the entire upper airway of if you're using the ET tube. Easier breathing, increased comfort, and it's going to allow your patient to eat and speak, whereas the ET tube, you can't. It's blocking the entire upper airway. Now we can go parts of the tracheostomy tube. We have your flange, or let's see, your plate that's going to go on the outside. Your outer cannula. Which can be this little right here. Our inner cannula, I don't know if there's no little picture here for me to point out the inner cannula, but basically, you see that you have a connector for the disposable inner cannula, which is this guy right here. It's our inner cannula. Go onto that. I guess this wasn't a pretty good picture because I have to draw the inner cannula and the obturator. But anywho, this is the obturator. A little doodad right here. It's used for any complications that are related to your trach. Always, always keep this at bedside for patients who have a trach. And your cuff. There are other two parts that I like to point out, and that's the pilot balloon. The pilot balloon is a port attached to the tubing that inflates the cuff at the base of the tracheostomy tube to hold it in place within the trachea. The balloon inflates along with the cuff, and it serves as an indication of how much air pressure is in the cuff. For check-off purposes, we're going to use the shoelace neckties, which is going to be on the sides of your plate. At the hospital, we do have Velcro ties, but in our trach kits, they are the shoelaces. Just to make your guys' check-offs a little bit more challenging. There are 3 types of tracheostomy tubes. There are cuffed or uncuffed, fenestrated or non-fenestrated, disposable or non-disposable inner cannulas. Our cuff type tubes are for patients on ventilators. It prevents aspiration with feeding tubes, and it can decrease the gag reflex and gastroesophageal reflux. The cuff tube measures an increased or improved ventilation and oxygenation. It also is the most used type of tube. As far as uncuffed, these are usually plastic or metal. They are used in non-ventilated patients. And of course, if it's uncuffed, patient will have no difficulty swallowing because there is no balloon that is blocking the upper airway. And it's pretty much a low danger to aspiration. Let's see. Complications with the cuff, well, it depends on the pressure of the cuff that is regulated by the pilot balloon. So high pressure can lead to necrosis. Low pressure allows the movement of the trach and airflow to escape. So really, here is your trach. And this is what a happy trach looks like. No damage to the sides, walls, or blocking any of the capillaries or little tiny arteries. Now, if you were to put an extreme amount of pressure into the cuff, well, the balloon's going to inflate towards the walls and pretty much block all the blood flow which leads to necrosis. And now you got a necrotic trach or esophagus, or pretty much your airway is going to be compromised because now you have cell death. It's a little cut off here, but let's just say if you didn't apply enough pressure into the cuff, well, now you have a greater risk of displacing the tube and now you're allowing airflow escape to the sides. Oh man, airflow can now escape through here, and now it's not going to the proper area, which is to your lungs.
The Passy-Muir tracheostomy and ventilator swallowing and speaking valves incorporate a unique patented design feature that translates into significant benefits which are exclusive to the biased closed position no-leak design. To understand the principle behind the Passy-Muir patented feature, it is important to first understand how an open position valve operates. An open position valve uses a membrane or diaphragm to perform the valve opening and closing functions. The membrane flexes during inhalation, which allows air to pass around it and through the tracheostomy tube. When the inhalation cycle reaches its peak, the membrane temporarily relaxes and returns to its normal position. At this point, the valve is not actually closed. Reversed airflow, which is produced by exhaling, is necessary to force the membrane against the valve body to produce a seal. Before the membrane actually closes, there is a short time lapse where some exhaled air can escape. In addition, some common breathing patterns create an airflow phenomenon that can cause the membrane to vibrate or oscillate, which prevents it from completely sealing, resulting in noise as air leaks out. The open position valve allows secretions to travel up the tracheostomy tube and potentially occlude the tracheostomy tube in the valve. The Passy-Muir valve has a patented feature that virtually eliminates the possibility of these kinds of problems. This feature creates a closed position, no leak condition. The membrane's outer perimeter is forced to normally be in a state of compression against a lip inside the valve body. In a relaxed state, the valve is completely sealed, not requiring reversed airflow to close it. When inhalation begins, the membrane easily bends out of the way to allow air passage with minimal resistance. When the inhalation cycle reaches its peak, air stops flowing and the membrane instantly returns to its normal fully sealed position. This is the closed position no leak feature. As exhalation begins, the valve is already closed, and air immediately follows the path of least resistance up through the trachea and past the vocal folds, exiting through the nasal cavity and mouth. Because the valve closes at peak inhalation, a column of air remains in the tracheostomy tube at all times, creating resistance to secretions entering the tracheostomy tube and the valve.
One important part of our trach is the inner cannula. The inner cannula pretty much fits inside the outer cannula. It has a lock to keep it from being coughed out, and it is removed for cleaning. It allows the maintenance of tube patency. It could be non-disposable or disposable. For home purposes, we usually use the Shiley. So most common inner cannula that we use in the home setting or the hospital setting, specifically at Pioneers. So what are our trach care guidelines in our nursing assessment? Well, if you have a trach patient, you're going to, of course, assess at the beginning of each shift. You're going to look and listen to your patients. Look. Gotta look and listen to your patients. See if you actually got airflow going through. There are no signs of agitation or irritability. Vital signs and pulse oximetry, oxygenation and humidity. And you need to know if your patient needs the head of the bed elevated to 30 or 40 degrees. So what's in our respiratory assessment? What are we looking for? Respiratory assessments. Assessment. Huge one. Patency. The work of breathing from your patient. Breath sounds. Are they shallow? Are they sounding gurgly because they have something plugged in there? Or are there secretions that need to be suctioned out? Coughing. My patient has a fenestrated tube. Are they actually coughing it out through the mouth, or is it because it's plugged somewhere and he can't move any of the secretions? My trach site, is it bleeding? Is it nicely clean without infection? There's no yellow pus running around. There's no odor. Let's see here. Collaborative care team. Who can we call about our trach care? Well, your respiratory therapist. Please follow your MD orders. Oxygen humidification. Ventilator settings. This is what I would like to talk about, and I cannot emphasize any more. Ventilator settings. As an RN in the state of California, do we touch the ventilator settings? We do not ever touch the settings. Although that we are educated in the settings and we can recommend it, but our scope of practice does not include ventilator settings. I see this multiple times in accounts. There are your patients on the ventilator. You would like to change the settings because you want to optimize, or you want to start weaning your patient off the ventilator. That is something we cannot do. So if your respiratory therapist notice changes in the settings, they will now officially document it into the patient's chart. Say that the nurse made the vent change without the consent or recommendation of the respiratory therapist, and should anything happen to your patient because of the RN ventilator setting changes, it will come back to you, and basically that is harm to the patient, because that is not within our scope of practice. Questions you should know about your patient's trach. Well, let's see. We want to know, what type is it? Is it in a cannula disposable or non-disposable? Is it a Shiley? And what size is this? Is it cuffed or not cuffed? Is it fenestrated or not? Does this patient have a plug? And how long, or what is the goal of using this plug into weaning off this patient? And of course, you always need to have your safety trach equipment at bedside. It might be common sense to make the decision whether or not your patient needs to be suctioned, but you need to consider, are they hypoxic? Are they showing signs of shortness of breath, cyanosis, restless, anxiety, or desaturation? Has their work of breathing increased? Has the amount of secretions increased? Can I hear those secretions without my stethoscope? And is there a blocked airway? So there are a couple complications with our trachs. Remember, we can cause hemorrhage if the cuff is inflated with so much high pressure that can cause necrosis and bleeding, a pneumothorax from blockage, a dislodged tube, and we'll get into that, infection, aspiration, or tracheal damage. Now, I want to talk about the dislodged tube and that lovely obturator that you have placed on bedside. So, what if you got a confused patient or child who decides to pull their entire trach out? This is like the absolute nightmare of all tracheostomies. And the most common reason for accidental dislodgement are altered LOC, you're turning your patient, copious amounts of secretions, and poorly secured trach ties. If the entire trach decides to come out, you have two choices. Put the trach tube back in, or number two, you're going to wait and see how they do. Now, sometimes when it is a chronic trach, it's nice and open. The patient has time to go ahead and grab the supplies to replace it, and they can breathe okay-ish. However, if it's a newer trach, and especially if the patient is ventilator dependent, you're going to have to act really fast. So what happens with the dislodgement of a chronic tracheostomy? Well, if you have a trach that is older than 7 days, that is enough time for the stoma to stay open if the trach is removed. And basically what you're going to do with a chronic trach is you're going to provide the oxygen, monitor your patient, alert your doctor and respiratory therapist, and you're going to anticipate tube replacement. Now, if you have a new trach that is less than 7 days old, a nice fresh trach will become unstable if it dislodges. Now, sometimes new tracheostomies will be sutured in place, but that doesn't mean dislodgement cannot occur. So what are we going to do? Well, call a code, because now your patient's airway is extremely compromised. Grab that ambu bag and start ventilating that patient. If your trach tube was secured with sutures, cut those sutures off and remove that tube, because now with that obturator that you have placed and taped at bedside plays an important role. To reinsert that tube, you need that obturator to guide it. So typically the obturator that came with the patient's trach will be taped to the wall or bed. This is so you can quickly grab it and reinsert the tube. Ideally, you want a nice, clean, fresh tube, but if the current tube is only what you got, then don't worry about it. Your patient is compromised at this point. Once you establish that tube, you can change it later. So you remove the inner cannula from the trach, and then you're going to replace the inner cannula with an obturator. Lubricate the tip of that outer cannula with the obturator to make the insertion easier. Place the outer cannula into the patient's stoma, hold the trach tube in place, and then you can now remove the obturator and replace it with the new inner cannula. Secure the tube with the trach ties, and now you're ready to optimize your patient's oxygenation. Another tracheostomy emergency, occlusion. Let's say your patient has a trach, is on a trach mask, and you heard in a report they have thick, copious amount of secretions. So in report, copious amount of secretions. And then suddenly the monitor alarm goes off, and you see that your patient's O2 saturation has dropped to 62%. So now we are in hypoxia mode. What? Knowing what you do about their thick secretions, you hurry into the room pretty confident that you know what the problem is. You see the patient struggling to breathe, squirming around in bed, and banging on the side rails as he mouths, I can't breathe, I can't breathe. So what are you going to do about it? Well, because he's on a trach mask, that doesn't mean, or actually, he doesn't have inline suctioning. No inline suctioning at all. So with one in hand, you crank up his oxygen and you quickly grab the suction kit with the other. You put on your sterile gloves quickly and proceed to sterile suction with your patient. And you pull a thick, nice, juicy glob of secretions. Ew. A nice, juicy plug. And now all of a sudden, you watch your patient's O2 sat level come back to 97%. So that was a close one. Mucus plug. So if your patient has a copious amount of secretions, there is a greater risk for a mucus plug. So if you saw back here, there it is, the nice, juicy mucus plug. So now this airway is compromised because I can't get any air through into my respiratory system. Okay, so now that you've cleared the occlusion, we still can't breathe. What if you can't get the occlusion cleared? And sometimes that happens. So the first thing you should do is taking out the cannula and replacing it with a fresh one. Most of the times, that's going to do the trick. But if the occlusion is further down and not within the tube itself, you'll need to call for help and start manually bagging your patient. In theory, this could push the occlusion further away into the airway, but the chances of it including the entire airway further down is less severe than the fact that it is occluding the entire airway right now. So basically, your patient's going to need a bronchoscopy to clear out that plug and fluids and nebulizer treatments to thin out those secretions so the patient can cough them up.